My name is Steve Schweitzberg on behalf of my co-moderator, Alberto Chuslab, who is the president of the IFSIS, the International Federation of Endoscopic Surgical Societies. We'd like to welcome you to the plenary session. One or two housekeeping items. The speakers will have 10 minutes. Please try to stay on time. We'll then have an opportunity for questions and answers. And then immediately following this session at 9 o'clock, we will move to the plenary session. So without any further ado, I'd like to call up the first speaker. Perfect. Dr. Balazs Lengyel, and he's going to speak on laparoscopic cholecystectomy after a quarter of a century. Why do we still convert?
Good morning, ladies and gentlemen. My name is Balazs Lengyel. I'm from the Department of Surgery, Brigham and Women's Hospital. I would like to thank the opportunity for the Society for presenting here today and the privilege of the podium. I have no disclosures. Laparoscopic cholecystectomy is currently the gold standard procedure for gallbladder removal in the United States. Despite our improved training and experience and 2 decades of laparoscopic surgery, our conversion rate of up to 10% is still reported in the literature. However, it is often unclear why exactly conversion occurs. We believe that conversions occur either in response to complications or in anticipation of difficulty during the procedure. Some people promote early decision to convert rather than carrying out a longer laparoscopic case to prevent a potential complication during the procedure. This is also further emphasized sometimes in medical legal cases where a prolonged laparoscopic case is used as an evidence of poor surgical judgment against the operator. We also believe, however, that there is a potential for a paradigm shift nowadays because surgical experience in the conventional open technique is minimal. A resident can finish a training program with minimal to no exposure to open cholecystectomy. So therefore, open approach may no longer be as safe of an alternative as it used to be a decade or 2 decades ago. So the ultimate question remains, should surgeons persist with a longer laparoscopic procedure and with a laparoscopic approach and have a higher threshold for conversion, or try to carry out the procedure with the conventional method and make an early decision to convert? Our study had 2 main objectives. The first one was, therefore, to compare outcomes of prolonged laparoscopic cases to converted procedures to test the hypothesis whether prolonged laparoscopic procedures are associated with worse outcomes or not than converted. For this, we used our institutional NSQIP database and financial records between the time period 2002 and 2009. We identified 2 main groups of interest. One was the converted group, and the other one was laparoscopic cases that had prolonged procedure times. A case must have available OR notes and financial data in order to be in our study, and if it included other procedures or treatments during the same hospital admission, the case was excluded from the analysis. Our outcomes variables were procedure time, morbidity and length of hospital stay, and total OR and hospital charges. We used multivariate analysis. So our first group was identified from 1,122 laparoscopic cholecystectomies with a median OR time of 63 minutes. We identified from this group the longest 10% of the cases, which was initially 120, and out of which 101 met our inclusion criteria. The converted group was initially 70, and 66 cases met our inclusion criteria, and therefore were part of the analysis. These are the baseline differences in terms of demographics and comorbid conditions. As you can see, there's a significant difference between long laparoscopic cholecystectomies and converted cases, with converted cases having more men and older patients in the group, and also included more hypertensions than the long LC group. Comparing the two groups, we found that the median operative time for these prolonged laparoscopic cases were an average of 19 minutes longer, and this difference was significant. This was also reflected in the total OR charge, just one line underneath, with long LC cases being more expensive in terms of OR charge. However, the length of hospital stay was much shorter and significantly shorter for the long LC group than for the converted group. And also the total hospital charge was significantly smaller for the long LC group than for converted. There were no significant differences in complication rates. Therefore, we concluded that prolonged LC cases are not associated with worse outcomes than converted cases. And in the current era, the decision to convert should be primarily based on safety and not OR time. Therefore, we decided to continue with our converted group and have our second objective of our study to identify the reasons and the determinants of conversion. What was the thought process behind the conversion and the decision? For this, we used our converted group, and we asked two blinded reviewers, two of our minimally invasive surgical fellows, to review the available operative notes on the converted cases and categorize them based on three main factors. The number one was the extent of laparoscopic dissection, what we called effort scores, so the effort from the degree of effort from the surgeon that was made to carry out the dissection, the number of ports at the time of conversion, and the reason for conversion. Inter-rater reliability was carried out calculating the kappa coefficient. So the effort scores between the groups were categorized as immediate, some dissection, or extensive dissection. Immediate was a case where we found minimal attempt for dissection, and we categorized it as gallbladder retraction was not even attempted from the surgeon. The some dissection, well, the Coil's triangle was properly identified, but dissection was not carried out. And extensive dissection, well, the Coil's triangle was in fact dissected. As you can see, 48% of the cases were in the immediate category. The number of ports revealed that 33% of the cases had only one port inserted at the time of conversion. The reason for conversion were mainly elective or emergent. Elective was a case if it were converted due to inflammatory process, non-inflammatory adhesions, or unusual anatomy. And emergency was a conversion if it was carried out due to an intraoperative complication such as bleeding or concern for CBD, common bile duct injury. This showed a substantial agreement between the reviewers. Based on the degree of effort that was carried out and the number of ports, we decided to come up with new categories because we thought these two, the number of ports and the degree of dissection and effort, are two surgeon-related factors, and we wanted to categorize them, calculating and incorporating these two together. Category 1 was a conversion in our new system if the surgeon was unable to access the abdomen. The reason here that laparoscopic dissection could not have even been made, we decided to not continue on with Category 1 conversions. Category 2A was a conversion if the case was converted with minimal effort from the surgeon's side, with a case being immediately or with less than 4 ports inserted converted. Category 2B was a conversion if it was carried out with some dissection or with 4 or more ports inserted. And Category 3 was a conversion, just like the emergency, when an intraoperative complication occurred. This is the ratio between the different groups. As you can see, most of the cases were in Category 2A, where minimal effort was made from the surgeon, where there was immediate conversion or less than 4 ports inserted. Comparing these different new categories, there were no significant differences in terms of number of complications, length of hospital stay, or charges. However, operative time was significantly shorter between Category 2A and Category 2B. So in conclusion for this part of the study was, due to the fact that there was no significant difference between category 2A and 2B conversion. And category 2A, which was most of the cases, were carried out after minimal dissection. We decided, or we recommend, a genuine effort in the future for laparoscopic surgeons to continue on with the laparoscopic approach as long as they are placing the minimum number of 4 ports before they decide to convert. And of course, in the future, the ultimate goal would be to better understand the reason why conversion occurs and collect data on conversion to provide better guidelines to the surgeons. Thank you very much. I would be happy to have questions now.
This paper, you have the microphone? This paper is open for discussion. If you would state your name. Nat, I can barely see who you are in the lights, so, and where you're from.
Excuse me, Nat Soper, Northwestern. Very, very nicely done. I think it's something that we need to look at closely. Did I miss it, or did you not state if there were any common bile duct injuries, and if so, in what groups those were? Number one.
Yep.
Number two, did you look at surgeon factors? There have been some studies that look at people, MIS surgeons versus non-MIS surgeons, and the rates of conversion.
Thank you very much. That's a very good point. Category 3 included the cases where we decided that those cases were carried out due to an actual complication, bleeding, CBD injury, or even concern for CBD injury. And mainly the cases included surgeons who had the same experience during this time period.
Morning, Dan DeZiel, Chicago, Rush. Nice study, nice presentation.
Thank you.
I have some concerns about how valid it is to compare the two groups that you compared, however. It looks like you use the OR time as a marker for difficulty of the case, which may or may not be true. You have a teaching institution. I don't know who did the cases. I don't know if this was skin-to-skin time. You know, did the medical student do the port site closures, et cetera? So I think it's difficult in that regard to come up with any clear conclusions because I'm not sure that the length of time correlates with the true difficulty of the operation at the operative field.
Thank you very much. It's a very good point that you're asking there. I tried to phrase it in a way, and actually I called it as degree of effort. So a case being immediately converted really meant that there were no effort made to retract the gallbladder. So there was a slide that stated the definition, and the gallbladder retraction was not carried out. But yes, that's right. Time, based on time, it should not be compared.
Andy Morfessis, Fayetteville, North Carolina. I want to ask, were there any deaths in your group? Deaths? Did any of the patients were deceased after the surgery?
No.
Okay.
There were no mortality.
The follow-up is, what do you attribute your very good results? You have 1,200 cases here without a mortality. What do you think it had to do something with your team, or how many people were working at one time? Were there 2 or 3 surgeons on every case?
This is the regular 5 people in the OR, the 2 surgeons generally, yes.
Thank you.
Thank you.
So I just have one comment to elaborate on Dr. Soper's comments. You know, studying the surgeon factors will be very illuminating because in some cases the experienced surgeons will persist where the novice surgeons will bail out immediately, and in other cases the experienced surgeons will immediately recognize a case they can't do and say, I can't do this. And so using time as your criteria is not going to be as robust if you don't include the surgeon factors. So that was terrific. Thank you very much.
Thank you very much.